Today we'll be doing a review of the Module 10 PowerPoint for HIMT 2410. Chapter 10 is about our value-based purchasing programs. Here's a list of your learning objectives. On the test, there will be 15 questions, 2 true and false, and then 13 multiple choice. So a good bit of the test comes from some of the beginning of the chapter where it's give you definitions and terms to kind of describe what a value-based system is. A value-based purchasing, which is a VBP, and a pay-for-performance, P4P, reflect a movement in healthcare that is looking at ways to ensure that quality is being met, but also to help fight the rising cost of healthcare. So they're looking at the keeping quality and safety, but trying to lower the cost of services. So the biggest key with this framework is that it's working to improve efficiency, which is a reduction in the cost to treat each beneficiary. So you can see that here in this PowerPoint. So they are looking to improve quality, safety, efficiency, and value. They link quality, performance, and payment. They do have targets, and the targets should be what the focus is, and there's 3 of the big areas. First, they look at problems in terms of quality or cost. Secondly, the proportion of the population that's covered either by service or by the provider. And then they look at the availability of valid and reliable performance measures, because a lot of this is based on showing performance by that physician. So we have 3 fundamental characteristics. We have measurement, transparency, and accountability. All of these are endorsed by large private employers and coalitions that are looking for ways to increase quality and safety. So measurement is our first one. It looks at collecting the data. It's getting the facts for the stakeholders so that people know what choices there are. Transparency is next, and it kind of influences the behavior of the patients, the providers, and also the payers. They're looking for a better outcome. So transparency is how we make that information available to the public so that those stakeholders can make informed decisions. They need reliable, clear information about cost, quality, efficiency. It needs to be in a form that they can understand. And then it also should address consumer experiences. And then the third characteristic is accountability, and this is the obligation to provide the information to be answerable for and to justify the actions. This holds organizations and individuals responsible for their performance. So just a little bit of information before we look at this slide. Our pay-for-performance payments are used to reimburse providers that performance is based and includes incentives. It aligns payment with incentives for certain performance targets. And so a target should be something that's measurable, which you can kind of perform a judgment, maybe a quality, a process, a compliance. Incentives can be positive or they can be negative, which means at that point the incentive would become a penalty. We've had the P4P system since the 1970s. The Byright Corporation was working on it. The late 90s to the early 2000s, it was private and public. And then in the mid-2000s, there were more than 100 organizations that had a VBP and P4P. They had health plans, employers, Medicare, Medicaid. They kind of target doctors and HMOs. So with our VBP, the payment model holds healthcare providers accountable for cost and quality of care they provide. And there's 3 definitions of those values. You can see them listed on page 274. excuse me, they kind of tie performance to the reimbursement. So let's look at these kind of parts to the VBP and P4P. So we have goals. Our goals are to improve clinical quality, improve cost affordability of healthcare, improve patient outcomes, improve the patient's experience for receiving care. And then we have the Institute for Healthcare Improvement improves the patient experience of care. It improves the health of populations, and it reduces the per capita cost of healthcare. So this kind of guides the efforts to optimize performance. They're kind of broad, and they kind of are all conclusive. Sometimes they'll actually have sub-goals. Now, as far as what drives these, there were 3 reports that came out. There was To Err is Human, Building a Safer Health System. It looked at hospital deaths and then also errors. Crossing the Quality Chasm, A New Health System for the 21st Century. It looked at how we could redesign the payment and design it toward quality. And then Rewarding Providers, Performance Improvement Aligning Incentives to Medicare. So it again found that there was poor quality, and it suggested that by assigning incentives, then we could try to encourage quality improvement. So all of the reports called into question the quality and safety, and also looking at the cost of those healthcare designs. And those were the 3 drivers for the programs. So most recently, most of our reports come from the AARHQ. That's a quality organization where they grade healthcare based on points that are received. So in our private sector, we have some initiatives. It's also called a coalition. These groups are also working to help improve quality. So we have the Leapfrog group. Their goal is positively affect quality and affordability by leaping forward. These are mainly large employers. We have the Altarium Bridges to Excellence. They're a nonprofit. They do research and consultations to help provide better care and health. We have the Integrated Healthcare Association of California, and their goal is performance measures. They're a nonprofit, and they set up performance measures for participating doctors and do an annual performance score. Their work is similar to HEDIS. Then we have the National Alliance of Healthcare Purchaser Coalitions. They improve the value. This is employer-based health, and they look at employer-sponsored health plans, safety, efficiency. And then we have the National Committee for Quality Assurance, NCQA, and their goal is to improve the quality of health care. They want to transform it through transparency and accountability. They actually started in 1979, and they look at some of the same HEDIS indicators that are used when we are accrediting programs. Now, when we talk about private sector, we also have the public sector, which would be where Medicare is involved. And then we lastly have international. So these VBPs and P4Ps are in many countries. There's a list on page 278 that lists all of the countries where we actually find these systems. In the United Kingdom, they have quality outcomes and have the world's largest. They have outcomes for many diseases. Canada pays for results to decrease non-urgent wait times. Australia looks at immunizations, veterans. Italy is similar to Canada. Some do have diabetes care goals. So just keep in mind that this is something that's not only found in the United States, it's something that's been going on in our international community for a while. So now we do have a physician feedback program, the value-based payment modifier, and it includes all physicians regardless of their practice, and that was to be implemented by 2017. As far as the research, little evidence is to support the use despite the proliferation, so it's kind of inconclusive. There is on page 278 and 279 some review for research there. They found that it doesn't really change professional behavior yet, and they're hoping that as we continue on, we can get more information that would help guide that impact in the discussion. So these are the listed advantages and disadvantages. Our advantage is that it demonstrates a commitment to quality care. It establishes an infrastructure for reporting quality, rewards for providing quality health care, a transparent process of rewards, the ability to focus on underserved or high-risk groups. The disadvantage is that implementation of interventions not evidence-based. There is a potential for unintended consequences. It can be difficult to measure processes and outcomes, for example, looking at patient compliance. The potential cost of implementation could be better spent on other efforts, and then better documentation of care rather than the actual better quality of care. So we have two primary or major categories of models. We have reward-based and penalty. A reward is compensation when the targets are met or exceeded. One of the biggest incentives is a higher fee schedule for superior performance. There's increased payment rates for superior providers. Then our penalty-based is compensation can be withheld if the targets are not met, performance is not improved, so they would have a lower schedule for an inferior performance. So penalties a lot of times can be used to try to get a corrective behavior out of a physician. Now, patient-centered medical home, also known as a PCMH, is the model of primary care that seeks to meet the healthcare needs of patients and to improve patient staff experiences, outcome, safety, and system efficiency. This actually came into be back in the 1960s, working in pediatrics. They were looking at trying to come up with a comprehensive care that met everyone's needs. It's organized by health plans, states, payers, providers, multiple patient populations, disease states, and then geographics. They do have coordinated care, and then they do have a lot of support services that go along with it. So your core features of primary care are continuous and long-term, comprehensive, prevention, wellness, acute, chronic care. Coordinated across the continuum. It's patient-centered, looks at the patient's needs. The whole person engages the patient and the family, recognize those unique needs. And that's going to be combined with a multidisciplinary team, an electronic information system, online portals, chronic disease registries, population-based management, and continuous quality care. The fee schedule is in combination with what's called PMPM and P4P bonuses. So this is the most common payment. It's fee for service, and there is an increase based on the number of members they see a month. So our results show that a small positive effect on the patient's experience, a small to moderate positive effect on the staff. There's not enough evidence to determine clinical and economic outcomes, and then no evidence for an overall cost savings. So that's something that they, again, are still using and looking at, is it the best option? We have accountable care organizations. This term was first used in 2005. Researchers at Dartmouth. It was a model of healthcare delivery and payment. You have a set of providers who are jointly held accountable for achieving measured quality improvements, reductions in the rate of spending, growth, health, and healthcare cost of its designated population. 3 characteristics: the ability to manage patients across the continuum of care, including acute ambulatory, and post-acute health services, capability to prospectively plan budgets and resources needs, sufficient size to support comprehensive, valid, and reliable measurements. So this was a way to provide coordinated high-quality care to Medicare beneficiaries with the goal of coordinated care, getting patient the right care at the right time. It brings together doctors, hospitals, and other providers to provide efficient, low-cost, and effective, free of duplication care. So the Affordable Care Act, ACA Section 3022, CMS was required to establish the Medicare Shared Savings Program, MMSP, which was to promote development of ACOs. Providers were rewarded with part of savings if they could decrease the health care cost. CMS refinement and delineation of general definition. It's a large entity recognized under state law, could be federal and tribal. It's composed of a group of ACO participants, providers of services and supplies, that have established a mechanism for shared governance. They started with a 3-year agreement, and the ACO participants coordinate the care of traditional Medicare beneficiaries. The ACO is accountable for quality, cost, and overall care of the beneficiaries that are assigned to it. And that's going to be identified by a tax ID number. So basically, they're accountable for all cost of a certain designated population. So the ACO is going to be formed by more than one person. It can be a group practice, a network practice, partnership. It could be hospitals, a CAH, could be a rural health clinic. And the participants work together to manage and coordinate care for Medicare for service beneficiaries. They are responsible for the cost and the care. They do operate under a risk model. It can be one-sided, where the ACO shares the savings with Medicare but does not share the losses. So here's how it works. Medicare beneficiaries are assigned to an ACO based on their claim history. The beneficiary can use providers inside ACO and outside. The ACO receives a reward shared savings if targets are met. ACOs and non-ACO providers are still paid under regular PPSs. So your ACO has shared governance. The leadership can be a combined. You may have people in leadership from different organizations. We have 3 different ACO programs. We have the MSSP, which is a permanent part. It's got better quality of care. It's better health for populations. So it became operational in 2012. There are 480 ACOs that served 9 million beneficiaries in 2017. There are 3 tracks, and you can see the tracks in your textbook on page 283 in figure 10.2. We have a next generation ACO, which was developed in 2016. It has 44 ACOs. It's 2-sided for those who have experience in coordination of care. Higher levels of risk and reward, small financial incentives for the beneficiaries. And then we have the Medicare ACO Track 1 Plus Model 2018, which introduces a downside risk. So CMS believes that the ACOs provide a better quality care despite the minimal success with savings. It does look at continuing and doing some research about the increase in the quality that is being provided with those. So these are your tracks. This is the 1, 2, and 3, and so you can kind of see one-sided, two-sided, and that's on page 283. Here's an example of the track 1 with a 3-year contract period. This is figure 10.3 on page 284, and you can see how this has started out here. You got 9 million, 8 million, 7 million, so they're hoping by the 3rd year that that will be a decrease. Now, it is important when considering the VBP and the P4P to look at allocations and how those assignment of those incentives is going to occur. So the word attribution is when we determine who rendered care, who's responsible for the quality of care, and who is accountable for that care. And that way we make sure that the cost, penalties, incentives are all charged to the correct person. So we have some different concepts. We have the perspective, which uses data from a review year to assign patients to the next performance year. So it's going to be based on your past history. Our performance year assigns patients at the end of a performance year based on patients that were served during that performance, so who was treated. It better reflects the ACO's population for which they're held accountable. And then we have a hybrid, which kind of combines both perspective and performance. The end result's the same as if only the performance was used. So it's looking more at past use. So they're going to use algorithms, and those algorithms are going to help to assign providers to the patients. Remember that because it's incentive-based, allocation reward must be fair to the providers to make sure that the person responsible receives that incentive. It also needs to be transparent. Everybody needs to know, it needs to be clear, and everybody needs to know who's involved in that. Performance measures, these are our indicators. This is how we make sure that it's accurate and fair. These are quantitative tools that provides an indication of performance in relation to a specified process or outcome. So we look at structure, process, and outcome. Our structure is the characteristic of the organization. Does it have an existence of a health information technology department? Process looks at the guidelines or standards of care. And then outcome looks at the end result of activity such as mortality rate. So the measurement is developed to also be labor intensive, and it measures different areas to determine if patients are receiving safe quality care. It can be used as a way to narrow down to get a different picture of what types of quality issues we want to focus on for our facility. So CMS does link quality to reimbursement. They have three aims. It's based on the CMS vision. The CMS vision is to optimize health outcomes by improving clinical quality and transforming the health system. So the three ways that they can do that is to provide better care for an individual, better health for a population, and then lower costs through improvements. CMS has 6 quality strategy goals: make care safer by reducing harm caused while care is delivered, help patients and their families be involved as partners in their care, promote effective communication and coordination of care, work with communities to help people live healthy, promote effective prevention and treatment of chronic disease, and then to make care affordable. And remember, one of the things about the incentives is that they use that higher fee schedule as a financial incentive if people are providing that quality of care. Now, quality reporting programs. So the facility or provider will maintain full payment when it successfully participates in the quality measure reporting. Table 10.3 is on page 292. In your text. So it gives you a list of some quality reporting plans that can be used. These are measures that are specific to the healthcare setting. So you'll see when you look at that, it's listed by if you're an inpatient, an outpatient, a long-term, a hospice, a home health. That report is for Medicare and non-Medicare patients, so they do look at the care for both. Most receive a 2% reduction for failing to successfully participate. So what that means is they'll get that would be their penalty of a 2% reduction if they don't follow that. This is the first step that's needed in starting that VBP. So these are, again, those goals that are needed for the value purchase. These are domains that we can look at to help us pay for quality. This picture is on page 293 in your textbook, and then the goals that kind of go along with it are listed on page 291. So they do say a value-based purchasing needs to be budget neutral. It does need to work within these domains, and it has to report from these domains. So we have communication, core coordination, community population health, effective clinical care, efficiency, cost reduction, patient safety, person and caregiver centered experiences and outcomes. And if you'll notice, some of that quality is quality of care as well as what is the patient or their family's perspective on the care they've received. So our hospital VBP program, IPPS, it is the CMS reduces the MSDRG base payment by 2% for all providers, and then it redistributes the withholding based on the facility's total performance score, TPS. So basically they're pulling out 2%, they're holding it. If you have high scores, then you're going to get it back. If you don't have high scores, then you're not going to get it back. So the higher the TPS is, the better and the more money that you'll receive. So again, the TPS, total performance score, is used to determine how much money you will get returned back to you. For every point increase in total performance, the provider increases payment by a portion of that holdback percent, which is that base rate reduction. This is part of your incentives. So kind of they're taking it away and giving it back. Doesn't necessarily seem like an incentive, but it does seem like a way to keep you from being penalized. So in our hospital, we have 4 domains: the clinical care, safety, efficiency, cost, patient, and caregiver experience. Those are each worth 25%. They're going to be scored. You can see there's some examples there. They are looking at 2 specific areas: the performance achievement component that looks at the facility's performance compared to all other facilities. That means that it has to be a standardized performance measure. And then performance improvement is the facility's current performance to their baseline. Now, another plan that we have is the HOA, Hospital Acquired Conditions. This looks at the quality of the care and items that could change the DRG to a higher payment and could have been prevented. So it reduces payments for conditions that are considered hospital acquired. It is reduced on a case-by-case, and there can be payment at a lower severity MSDRG. Figure 10.5 in your text is on page 295. And it kind of gives you a breakdown of how they actually determine that. Now, listed as are the 14 characteristics or conditions that fall under that HOA. Remember that in this case, they're going to be paid as though the secondary diagnosis was not present. And you can read through those 14. So facilities with a HAC score in the lowest performing quartile will have payments reduced by 1% for all their encounters. The table 10.4 domains is page 296 in your text. Each facility receives a report that has their HAC scores and a total HAC. So those adjustments are going to be reported as occurring during the hospitalization. The payment reduction occurs after the adjustments have been applied. So we're looking at a reduction to the total final payment on this. Hospital readmission reduction, because a lot of times people think with the quality that doctors are going to discharge patients a little bit sooner than they might need to be discharged. They came up with the hospital readmission reduction. It was established by the Affordable Care Act. If a patient returns to the hospital within 30 days of discharge from the original admission and the admission is not planned readmission, then unless there might be some exclusions, then the measured readmission for certain conditions of all patients, Medicare, non-Medicare, Hospitals can have up to a 3% reduction in their base MSDRG amount reduced for all admissions. So basically they're saying if they come back, you're going to get a reduction in pay. It's probably because that patient should have stayed longer. The IPPS MSDRG payments are reduced by a hospital-specific amount that acts for a hospital with excessive readmissions. Only specific conditions are included in the program for each year. So for example, these 6 areas have kind of been covered over the past 3 years: acute myocardial infarction, heart failure, pneumonia, chronic obstructive pulmonary disease, total hip arthroplasty, total knee arthroplasty, and then coronary artery bypass or our CABG surgeries. With our RDs, this is pay for performance. They're going to be also linked to quality. Facilities strive to perform as well as they did during the comparison period to avoid payment reductions. These are the domains: clinical, reporting, and safety. You can see that's 100%. If the total performance score does not meet standards, they'll receive a maximum reduction of 2%. With our home health valued purchasing, home health strives to meet the program goals and achieve high quality scores through improved planning, coordination, and managed care. These are currently available in the 9 states that are listed here. So these 9 states kind of compete for their quality. They can go against their own baseline and then other same size HHAs. This is a 7-year plan where they're kind of bringing it in, and it started in 2016. So for the payment year 2018, it was a 3%, and you can see as it goes through, it could end up by 2022 being an 8%. HHAs with the highest TPS will receive incentives applied to their final claim. HHAs with average will not receive an adjustment, and then HHAs with deficient will receive deductions. Table 2.7 is on page 298 in your text, and it kind of shows you some things that they'll be looking at. Our skilled nursing facility program, the TPS is calculated for each facility looking at an achievement and an improvement. CMS again withholds 2% to fund the program. 50 to 70% of that is going to go back to those with high performance. High performing facilities will receive the incentive. Those who fall on the lowest, 40%, will receive decreased payments. So in this, you're kind of ranked by your performance, lowest to highest. There's 2 measures they're looking at: is 30-day all-cause readmission and 30-day potentially preventable readmissions. Our quality payment program, our RBRVS, is mandated by the Medicare Access and CHIP reauthorization. It links your physician payments to quality measures and cost savings. This is what our incentive program is. There's 2 tracks. You'll hear a lot of people in field talk about the MIPS. The MIPS is your merit-based incentive. Then we have the advanced alternative APMs. So first of all, with the MIPS, it consolidates the Medicare meaningful use incentives, what we originally had, to the physician quality reporting PQRS and the physician value-based into one model. So it's going to link all of those plans into payments that are based on quality and efficiency. You'll receive bonuses based on the performance that are related to cost, improvement of your activities, quality, advancing care. Table 10.8 is on page 299, and it gives you some examples of how physicians can meet. All they need to do is show that they've met it, and it may be that they're documenting certain things. There was a 4% reduction in 2019 if you did not participate in 2017. The incentive increases each year until it reaches 9% in 2022. Measures are going to be updated every year. So it started in 2017, that would be applied in actually 2019. Our APM, these are models that have a significant risk for providers and offers potential. So some examples are listed there: next generation ACOs, the MSSP tracks 2 and 3, comprehensive primary care plus. These incentives deliver increased quality and cost efficiency. It was developed in conjunction with clinical community, and it can be designed for a specific condition or a specific physician, such as somebody who specializes in a disease. There are three criteria that have to be met, and those can be found on page 299 in your text. So we kind of have two tracks for them to receive either full or reduced. Some of it is based on your E&M services as a way to track it. In 2019, providers can receive a 5% lump sum based on their 2017, and then the 5% is going to be offered 2019 to 2024. If a provider participates in APM, they don't have to do MIPS, so you don't have both. But one thing with this is you'll notice the percentage stays the same as far as the incentive. There's no staggering and increase of the incentives. So as far as the future, the healthcare community has requested the CMS consider social risk factors such as socioeconomics, sociodemographics within the VBP. Social risk could include, but aren't limited to, income, education, race, ethnicity, employment, disability, community resources, and social support. So they are looking at a couple of reports. The first one, the social risk factors and performance under Medicare's value-based, was done by the Office of Assistant Secretary of Planning. It looked at the impact on quality. This came out in December of 2016. And then accounting for social risk factors by the National Academies of Science, Engineering, and Medicine in 2017. They analyzed and looked at could there be a harm if there's less incentives. So CMS is currently looking at results of both of these reports to see what changes can be made. They're looking at feedback from the healthcare, results from studies, and then also they're talking to patients to see what patients think of the plans. All right, so make sure that you know the VBP and the P4P, know their framework to improve efficiency, know the three targets that they can be focused on, know what transparency is, what does it have to do, what does it explain. Make sure you know when these organizations started, what drives them. Know whether or not we see it just in the United States or if we see everywhere. Remember that all of this was to go into place by 2017, so the feedback, the payment, the modifiers, all of that, and it did not matter what size. Know the two different models, reward and penalty. Know what your incentives are based on that fee schedule. Know what a PCMH is. Know the definition of attribution. Remember that higher fee schedule. If I don't participate in the quality reporting, what's going to happen to me? Remember, there's a reduction. In the hospital VBP program, know what's used to determine how much money they're going to get, that total performance score. Know about the hospital readmission. Remember, it looks at Medicare and non-Medicare, what established it, the ACA, and make sure that you know that there will be a reduction in payments. All right, remember 15 total questions. Good luck on your exam.